Okay, I believe we're on. And let me just mute this. Hi, everybody. Bear with me while I get the little bit of tech set up here. Here we are live on Facebook. I'm Lisa Paladino. We're here with Dr. James Thomas today. Thank you for joining us.
No problem.
Today, and welcome to everybody who's here on Facebook and anybody who may be watching this later on. Glad to have you here. Very exciting to be able to talk across the country. So here I am in New York, and we're talking to Dr. Thomas, who's from Washington State, and I'm in IBCLC in New York, and Dr. Thomas is a dentist in Washington. So I will let you give a little bit of an introduction, Dr. Thomas, and you can tell us a little bit about what you're doing over there in Washington and what your practice is like.
Yeah, so thank you, Lisa. I appreciate you having me and anybody who's joining us. Yeah, so by trade, I always say I'm a pediatric dentist. I graduated from the University of Michigan, headed out from Michigan. I grew up there, headed out to Seattle just to kind of start anew with my wife. And we started, as anyone would, a pediatric dental practice, which we were blessed. That eventually grew into two in a business center. And we were very passionate. My wife, Zdo, she's got some amazing skills with just brand and imaging. And we became very passionate in pediatric dentistry, how a brand could kind of change a concept of oral health. And it worked very well. We tried something very different. We've tried a lot of things in our careers as we've worked as an amazing duo together. And the brand was called Every One by One, and it's still alive today. And I'm just not part of it because in 2016, after a lot of great success and growth, I decided to part ways. I'm giving you a little bit about personal history, but I've never really fit into the dental mold, I guess you would say. I love dentists. I love what the profession has done for me and my family, both professionally and personally. But I've always just kind of been really seeking out less treatment and more just outcomes that could help preventative model. So we did that well with Every One by One, and the name became synonymous with coming to the dentist at age one, every one by one. And so when I walked away, I actually thought I wasn't coming back to dentistry at all. And it was really oral tethers that kind of caught my eye. And if you can imagine, with an amazing team, I saw somewhere around maybe 80 patients a day for 12 years straight.
Wow.
And you start to pick up things that are kind of trends in their bodies, health-wise. And obviously we're working in the mouth every day, which most of these people in the Facebook group, I would say the mouth is the king of the body, right? Everything that happens good in the mouth happens good in the body. And so we see trends and shapes and symptoms, which are problems. Symptoms are our bodies telling us what to do next. And so I just saw so many trends that we will probably eventually cover today in terms of things that are happening in kids somewhat below the nose in the midface area. And changes in their growth and development. So at the time I let go of the practices, I really didn't have a concept of that I was going on to tongue tie, or that this beautiful name called Latch would come about. But my wife and I are serial, just love to help people involved in the community. And we decided to take this on. And it has not been easy. Which I would say most of the people in the tongue tie group, if they're taking this on, they have found some bumps in the road, and we have found the same. But I'll share with you, hopefully over the next 45 minutes or an hour, how we've gotten past some of those, because I really do think we're getting a little bit of an edge here in Seattle. So very humbly, I will say that I think some people think that Health Latch is this big moving vehicle with this great Instagram following. There's just a little following that's kind of gotten to a kind of a trickle, but it's really myself and one other person. I am honored to work every day with an RN IBCLC of 36 years. Her name is Terry Gilbert, and Terry came it was a blessing that she came to me, because in the original days, I had this idea that I would just be doing tongue tie releases. But as soon as she came and added the value to the practice, it really kind of went to the next level. So today we really concentrate on just seeing 5, maybe 6 babies a day. But as I was saying to Lisa before we went on, that's a long day for us. We spend a lot of time with the families. I would say we're somewhat of breastfeeding triage at this point. And we believe in story first, function second, laser last is kind of our process.
Oh,
and what that means to us.
Just for a minute, I love that. I love that laser.
Yeah.
Because
yeah.
I think the art of that is lost in so many places. You know, many families are looking for that quick fix and thinking that just the laser or, you know, even a clip is going to solve all the problems. And we know, those of us who have experience working with these couplets realize and understand that it's so much more than the release, right?
It is. Yeah. And I jokingly say, as I sit to parents, because I do everything, I do all the technology, the answering of the emails and the phones, because I kind of run the front of the house and Terry runs the back. As I send patients into the room every day, I say, the gift at Latch today is Mrs. Terry Gilbert. And I am humbly a subcontractor to help her do her job just a little bit better, if needed.
I think lactation consultants all over the country who are watching us are standing up and giving you an ovation for saying that.
Yeah. Well, I mean, really a lot of
IBCLC is amazing, you know.
Yeah, really a lot of education had to happen really fast, to be honest with you, when I took this on. And I had heard from names like Dr. Gahary and Marty Kaplan, some of the people that would be on my Mount Rushmore of who led me in this direction. Mm-hmm. You know, I heard that you kind of had to know a little bit about breastfeeding to kind of be able to kind of talk the talk a little bit and understand what was going on. And it was only reading that got me there, and hanging out with lactation consultants. I go to a lactation journal study club at Children's Hospital here in Seattle, where again, I humbly learn about what's going on at the breast. And now I'm at the point, and some of it has to do with, if you can imagine, for the last, almost 3 years, I've been answering every phone call. Oh, wow. And so you hear these stories, right, over and over of what's going on. You know, you hear the, you know, you can almost even tell from the tone, you know, you hear that, oh, we just had a baby and baby's 6 days old and we were told that something's going on, and there's all this excitement, right? Yeah. And then you're also told on the high end of, you know, the 7-weeker, 8-weeker, 9-weeker, where, oh my gosh, I was told I was a champion breastfeeder, and then all of a sudden something happened right around that 7 to 8 to 9 week mark. That, you know, from the head nodding from you, Lisa, we all know that supply is dipping because the hormonal milk is slowing down. Yeah. And if there's no mechanical removal, there's some problems.
Yeah, I actually, I'll tell a quick story. I'm sure she wouldn't mind me mentioning, no names, of course. I saw a mom yesterday that was on her baby number 5, mm-hmm. and she never had a problem before. Mm-hmm. Or she never thought she had a problem. Of course, her nipples were sore for the first like 6 weeks with the 4th baby, but she just pushed past that, as I like to say. And yesterday she came with me with her baby boy. After 4 girls, she had a baby boy, and she's all excited, but she doesn't feel like her milk is there, and she feels like something's different. And one of the doctors told her that the baby might have a tongue tie, but it wasn't going to do anything to affect anything, not to worry about it yet. Yeah. So to make a long story short, yes, this baby was not stimulating her well, had a pretty almost an anterior attachment to the tongue. And, you know, she really is having a decrease in her supply because he's not doing what he needs to do to make her milk. Then we started talking about her prior children, and one of her babies is having a speech difficulty. One of her other kids isn't sleeping. And we started talking about, you know, all the connections, and it just brought it all together for her. She walked out of here like, I think her head was spinning, but she was enlightened, you know, starting on the journey to learn all about this. So the point that you spend the time and you're able to give the time to each family for that discussion is I think, amazing and key, because that's so different. I'm sure if you have dental colleagues were listening and they didn't have anything to do with moms and babies, and they heard you
Yeah.
say 5 patients a day, they'd be laughing at you.
Yeah.
As on the other side of my practice, I worked in busy OBGYN practices before I did this, and I would see 20 people a day, on a slow day, right, in about 4 hours. So they would laugh at me if I'd say, oh, I only have time to see 3 or 5 couples today, right?
Yeah.
So it's something that I think that we have to pause and appreciate that, and realize that that's what I believe that families should expect that from their providers, especially lactation, and if they're using a dentist that doesn't have a setup for that, they definitely have to find the lactation consultant who does have the time to do that, right?
Oh, for sure. And,
Yeah.
going back to that 80 versus 5, I mean, to be completely honest with you, as a dentist, seeing 80 people with a big team was pretty simple with really amazing systems and culture.
Right.
But seeing 5, I go home more exhausted than seeing 80, because there's so much of a dynamic of, that you're giving them information for the first time that's helping them put together the lights, and that takes time. That takes time to explain and to do it well. Tongue tie is not the big picture. Tongue tie is a problem that obviously when you take care of things typically get better. I like to underpromise and overdeliver. I tell every family every day, because that kind of sets everybody up for success, right? We conquer the knowledge. We hear mom's story. Terry puts together an amazing, communicative, discussion about what we should do next. What is the next step on the lactation side? And I generally find that if you don't solve mom's piece, that you could be the best phrenologist in the world, and we know there's some great ones out there. But ultimately, we don't get to the end of the race, which is, mom understands that she has to pump more, or mom understands that her supply is low and how to supplement, and she solves that nipple pain piece and gets the OBGYN for postpartum depression. So no, I mean, I give all praise to the RN IBCLCs and IBCLCs out there working with moms every day, because without them, this procedure that I'm doing at Health Latch very well is not going to be successful ultimately. Maybe some long-term benefits, and maybe we'll get to talk about that today. But that journey, and we always say our goals are your goals. Your goals are our goals. Like, what is your goal today? And we clearly ask them where they're trying to shoot, because when we put together all this information we just gathered, we're trying to help them hit that mark. And tongue tie is part of that. But I would say the bigger piece is the lactation piece.
Yeah, it's all tied in.
Yeah. And
I just want to take a minute to just acknowledge we've got quite a few people watching us, and I'd love it for everybody who's watching, or anybody who has questions, to post below the video. We'll try and get to all your questions, and if we don't get to them while we're live here, we will get to them afterwards. And give me some hearts and all those good emoji things to make us know that you're here and you're hearing us, and that the video's working, because that's always something that we worry about when we're on Facebook. is anybody actually out there, and can they hear us? But it looks like everything's going well. So the one of the questions that always comes up is what else needs to be done besides the actual procedure? We have a lot of brand new moms with little babies probably listening to us today, or who will listen to this later. And I like to talk about the signs and symptoms to look for. But in general, I think anytime that breastfeeding is having any difficulty, someone should, you should reach out for professional help. But just in your point of view, and if somebody couldn't come to you, what would you say would be the first steps about in processing the whole tongue tie issue, if that's what's going on?
I'm always been kind of idealistic, and I talk about, you try to talk about before the baby's even born, like as a new father, my kids are older now, but I just remember packing that bag, right, to prepare for the hospital, because at any time that water could break and we got to go, especially for that first one, right?
Right.
So, so I almost wish, right? I love brand, and one of the struggles I feel like is out there is that breastfeeding is branded as natural, which we all know it is. But when we say the word natural, we think easy, right? And there's not a lot of moms that walk into Health Latch that have said, "Hey, you know what? Gosh, this has been so easy," right? So yeah, it's just the supportive team for a mom. I always say the more hands on the babies, the better. I feel sometimes some internal guilt that I have moms going all sorts of different places, moms and dads, when we know they're super tired and sometimes financially strained by this big, amazing event in their life, as we all were at one time. But I kind of talk about it like a bar stool that usually has three legs to it, right? And the big leg is probably the lactation piece right off the get-go, that someone's seen a lactation consultant to have the assessment of their medical history and what medications might be affecting the supply. And it's all pretty much supply driven in those early days. And, how do we get supply to a point? Because we know, as we were talking about right before we went on, that, the suck is very important, and the suck is driven by the flow. So if the flow is not there, it's difficult. So that lactation piece is one of the arms, and I would include the phlebotomist as a team with that lactation. So that's kind of step number one. If like I said, I'm a subcontractor for Terry, if she needs that tongue release to do her job better, I'm there for her. And then the second and third piece to me, are the occupational therapist and the body worker, which is the craniosacral therapist. Oh, that's okay. And, the body workers, to me, is for that baby that's super tense and kind of comes out and rolling to one side. And some of the things we acknowledge, a little bit hypertoned, and we just want to help them find a relaxation point. And I can't speak to all the things that they do, but I know they do a lot, because when I see babies that have gone through body work, they're a different baby, and they're a more relaxed baby. Even intraoral, as we're doing our exams, I sometimes find the babies that have had body work, the tongue tie actually pops a little bit higher, which is easier for me to take care of for me and for baby. So, so the body work.
1 second there about that. Yeah. I try to explain to parents, and I think you're saying it a little bit better the way you see it pop. I feel that babies who have had body work have a more complete release, and also seem to have less of that, I hate the word reattachment, but less complications later. Let's put it that way. So do you agree that is that what you're saying in your own words, that it's a more complete release? Because more of it is exposed.
I do. Yeah. I feel like it comes to the surface. I feel like the genioglossus muscle around it is more relaxed, less tense. So thus, as I put my fingers, I use no tools when I treat the baby. So when I put my fingers in, I feel like the tether comes more to the surface, especially that what's called I know we probably won't get into all the nuances, nor do I want to for this short break, but just like, the posterior submucosal tongue tie is the one that you kind of gotta know what you're doing to find, right? You've probably seen 1,000 frenectomies, and you're starting to feel really comfortable with diagnostic, how you diagnose as a professional. So that body work will help some of those things emerge a little bit easier, especially maybe in your beginning days of taking this on. And so that's body work. And then for me, I only see up to 3 months now at Health Latch, and there's reasons for that. I can see everybody, and there's many people that want me to see more older babies, but there's just kind of this mission that I started that I really want to focus. I can't be everything to everyone. There are other good professionals in Seattle that are seeing older babies, and I refer to them every single day. But occupational therapy or occupational therapists are a big piece for me. If I was to pick an age, like I said, I only see up to the first 3 months. I feel like a lot of babies, by the time they hit about 45 days, they have some sort of suck swallow dysfunction. Especially with the anterior tongue tie that's tied all the way to the tip, where the tongue's just been kind of coming down. Even in utero, we know that swallow starts early, and we start to swallow the amniotic fluid. And even on some early babies, I already see the high bubble palates, the peaked palates. But I'm a big proponent of occupational therapists. And the hard thing about OT is not every OT sees babies. So you have to spend the time to make your network and go see these people and say, what exactly do you do? I bring them into Latch, and we just have sit downs, and so I can understand what they're doing and they can understand what we're doing. But I will, because I answer every phone call, and I am the doc, but I know that's rare that doctors answer phone calls. But if a baby writes into us at Latch and there are 2 months, I am already on the phone talking about an occupational therapist.
Right.
Sometimes the moms will actually make the appointment before they even see me, because I'm assuming that there's some sort of discoordination of that dysfunction of that suck and swallow. So even again, with an amazing, let's say we get 100% of that posterior tongue tie and we take it down to the base of the genioglossus without penetrating the muscle, and we do this great procedure, if that tongue is going to continue to just go to the same place, and we see that a lot in moms that have oversupply, where the babies I say that they're bellying up to the bar, but they're not buying drinks. They're just sitting there, and the milk's coming so fast that the tongue doesn't have to do anything. And even as adults, we know if that's right.
Drinking out of the water.
Yeah, that's right. And so we just know that those babies, their tongue doesn't have to do anything at all, and it's coming fast. And if you listen to their story, going back to story first, that'll become apparent before you even look in the mouth. I feel like the anatomical piece for me, where I actually physically look in the mouth, is so late in the game that and I've struggled with that a little bit, because people have asked me my process for diagnosing a tongue tie. Do you use these different factors and different measuring tools? I feel like I personally, and it's going to be a hard thing for me to teach others, because I know one way of doing this, and it's only one way. And I know in a dental practice, they're not going to spend 90 minutes with a mom. But I've just find diagnostically, like, those tools I struggled with. And I think they're great tools, but I struggled with them because I didn't get any closer to wanting to do that tongue tie, versus listening to the entire story that told me exactly what to do or not to do.
I have to agree with you. The tools that are out there, first of all, I think they're confusing, because the degrees of tongue tie, one is worse on one of the tools, and 4 is the worst on the other tool. So you don't know, depending on which tool you're talking about, the numbers don't make sense. And I like to describe it, so if I have to send a baby and talk, what type of tie it is, I like to describe where the attachment is from the bottom of the mouth, where the attachment is on the tongue, and what kind of restrictions I see. To me, it's more of a qualitative assessment than the tools. I think if we were doing research, we would have to use a tool, right, to sort of map it out and have a evidence-based, proven tool. Which sometimes I go back and forth about saying, well, how can, should I be using a tool? Would that be more scientific?
Sure.
But I think as a midwife, I'm more intuitive than scientific, and the story is everything. So and you're right. And that what you were just saying, I just had to back up to what you were saying about that oversupply baby. That weighs on those moms who come and say, I didn't think there was a problem because the baby was gaining. And everybody told us that everything was okay as long as the baby gains. And I've seen some babies who are overgaining, like really overgaining. And that's not necessarily good either. And they were severely restricted. So it's not, like, I want to shout that from the mountaintops. It's not about the weight gain. It's certainly not about the weight gain.
Yeah, and it's you know, it's probably the hardest thing as I start to get out there and teach a little bit. And I'm face to face. I've been very successful at being face to face with pediatricians here in Seattle, and the hardest thing I'll have to teach is that even though we're gaining on the growth chart, there might still be a problem. You know, that's hard for us as providers, even as a dentist, that you're searching. It seems like you're searching for something to do because everybody seems to be happy and satisfied and sleeping well. And but that's where I gave a speech in Phoenix that I kind of went off slide for a while, and I think it was well received. But that's where we've got to get with this, is that we're looking at the baby as a whole. You know, we're looking at mom, and if Terry's taught me anything, it's that it takes two to breastfeed, right? And we have to, you know, man, so much I've learned about just different nipple shapes and sizes and lengths, and I didn't know any of that, you know, before being educated by her over the years. So it's a blessing. But so I think to wrap that part up, the OT side, the occupational side, which is the last piece for me of that triad. And don't get me wrong, chiropractor sometimes comes into play and different providers, but I'm just trying to hit the big three. I've had to work really hard on that. I've met with some of the best here in Seattle, Robin Glass and Judy Simmons and Lynn Wolf, and we kind of talk about like, how do we get more providers that are OT to work with these babies, because and you got to have that passion, right? So for anything we do, just because you're OT doesn't mean you should be working with babies. Just because you're a dentist doesn't mean you should be working with babies if that's not your passion. So we're working on it, but the network part is really important to me. I would say the number one thing that I'm proud of so far at Latch is that when I traveled the country, the main thing I saw before I decided to take this on was the headbutting between providers, whether it be an ENT or a dentist or IBCLC. And so really the values that I wrote that have played themselves out so well, being radically kind and fiercely patient, and that's what we've been. I decided very clearly on early that I wasn't going to go around and say I was a tongue tie expert, which is very difficult to do because I felt like I had gained some knowledge that I wanted to share. But I really needed the community to actually deem me as an expert versus me telling them I am the expert, or I'm becoming the expert. And that's, sorry to just kind of go with the flow of the conversation. I mean, I learn every day with these babies. There's never an end point. There's never an end point. So I think we get kind of focused or funneled down the fact that we've mastered something. I don't think I'll ever master this entire process. I think I'm learning every day from the babies. So
I totally respect that, and I feel the same. And I believe it's really important for parents to realize that those of us who have dedicated our lives to this field are continually learning and learning from each other, learning with each other, you know, and if you find someone who is stagnant, then they're not doing the right thing, because this field is ever growing and ever changing, and there's new research and new ideas about the repercussions of tongue tie every day that they're, you know, it's coming more to the forefront. And I'm so grateful that it's starting to be that, I think the airway piece, which maybe we'll get into, is starting to recognize that, so this is an issue, it's connected to tongue tie, and what about those babies? You know, so I think we're at a great and exciting time to be in this field, but it's also difficult because sometimes we're talking way ahead of the people that are listening to us, because we've been so focused and a little geeked out on these topics. But I just want to go back 1 second to the OT. You brought up the OT. I feel like, you know, the team is key. And when I do my lecture, it's all about the team. And I think that what I like to say to people, especially if they're not in my immediate area and they're not coming to my team, I like to say it depends. The team is whoever, or the body worker is whoever has given the attention to this subject and understands the topic. So it could be a chiropractor. It could be an OT. I have a physical therapist that I work with who does amazing things with babies. She does craniosacral therapy too. So it's not like, in some places it may be the OT, it may be the physical therapist, but you don't want to just call an occupational therapist and say, hello, my baby's got a tongue tie, can I come to you? They may not know what they're, you know, what to do for that. So the networking is important. And that's, you know, one of the reasons why I formed this page and called it Tongue Tie Experts was, as you say, I don't want to call myself the expert, as you don't want to call yourself the expert, but it's getting people together who are the most expert. And sometimes it's the parents that are the expert.
That's right.
You know, and there's lots of parents on this page, and there's, you know, providers, and bringing us all together under the knowledge that nobody feels like they're really the expert on this, because this is an ever developing field, right?
Yeah, there's sometimes in the clinic, I feel like I'm seeing more and more. We've seen a good volume of kids at this point, but there's sometimes I have to say that I don't know the answer to this, but let me get you to the person that may, you know. And I think as providers, stepping back and having that perspective helps a lot. And you know, I would say when I travel and speak a little bit, one of the main things, if you don't mind if I take a second and touch on, that people ask me is, so how did you bridge the gap? Like, how did you make those connections? And so, this is going to sound corny, but the number one value at Health Latch is being radically kind. And so no matter what happened to me, I just continued to smile and continued to send out my reports. My reports are very detailed. They're 8 pages on each baby, and they go out within an hour of the baby leaving the office. That's faxed to every provider that's ever touched that baby. And I ask the parents, and that takes time to build that database of where are all these people in Seattle and what are they doing? But the more that they see this report and these beautiful pictures of before and after, and then it's eventually reconfirmed by the parents as they come back to see them, that's where you start to make change, or just have people ask you questions. So being radically kind is important. And what I mean by that also is, and I said this in my speech in Phoenix, is in general, if we could do anything for the movement of tongue tie, is to continually support primary care, even though they miss this, you know, because at the end of the day, that is the entrance point. And if I could say aside, I was in dental school at the #1 dental school in the world for 4 years. I then followed that up and luckily got into their PDO program for another 3.5 with a master's. I didn't figure out all of this until I went to the IATP, and it all kind of came together for me. So now I'm a dentist that was taught nothing about this. Now, how would we expect our medical colleagues to have any knowledge of this? Because I think the average is they get an hour and a half or something in one lecture in the course of their medical school. So, like, you know, Rajiv Agrawal, always says, you know, our minds don't see, you know, perceive what our eyes don't see. Or our eyes don't see what our mind doesn't believe. And so if we were never taught it, we'll look right past it, as I did for many, many years. And the only thing that brought me to the conclusion that something was going on is I was doing serial extractions on way too many kids. And it haunts me to this day that I did that, whether it be my own diagnosis or an orthodontist asking me to take out canines. And that just started this serial extraction process. It wasn't until I put together those pieces and saw enough volume that it came together. So supporting primary care, in my opinion, is very important, no matter what happens. And even when the parents are kind of mad that the primary care missed something, for me, it's asking them to be radically kind and going back and sharing their story. Because I tell them it's an evolving profession. So yeah, the network just basically came from just that yeoman work of, you know, rolling up your sleeves and looking at where everybody's at. And when a baby is in harm's way, maybe, you know, taking a report and walking it over to the hospital. As dentists, we don't like to do that, but you know, and going face to face with ENTs and oral laryngologists and people that we don't usually cross paths with. The easiest first steps were the naturopaths and the chiropractors. The chiropractors knew about this well before the dentist did. But yeah, so just sharing the love, I guess you would say. And I know it sounds corny, but it's just being radically kind.
It's absolutely amazing. So how is it received by pediatricians in your area? Are you having a good, are people becoming more open to the idea? And
yeah, so when I started to give you a perspective of dates, when I started this Health Latch in, I think it was August of 2017, when I said, okay, I'm done with pediatric dentistry. I'm going to open up a singular office that is going to be built out specifically for mom and baby. It was difficult. I'm not going to lie. It was very difficult. I got some tough notes, some tough emails, some tough calls. And I just continually kind of smiled through that. I actually, in the early days, had to give away the procedure for a while to generate enough stories to kind of start the conversation. And then once the conversation was started, I found, and if there's any advice I can give the providers out there that are trying to make those bridges, stop talking about tongue tie all the time. Talk about mom's supply, talk about airway. And if they ask what we think the root of the problem is, or they figure it out for themselves that, wow, there's this thing under the tongue with that particular mom, then the door is open to talk about tongue tie. But if we just constantly tongue tie this, it just kind of, because a doctor, a medical doctor, especially a generalist, is looking at the body as a general whole. So if you talk to them about the general conclusions of some things you saw, the extractions you had to do on so many kids, why, and just start that gentle conversation, that's where you get your end, because you're meeting them on a level playing field. If you just go right to tongue tie is the problem, I talk every day, I say I don't drink tongue tie Kool-Aid. I don't believe it causes everything, but it's kind of that pebble in the shoe when you go hiking. That's not a big deal at first, but by the end, it's a problem. And that will probably lead us into talking about airway maybe a little bit.
Yeah. So for those who are listening who may have young babies, and we're jumping ahead, we're having some conversation about things that we understand, but they may not. So talking about the extractions. So can you hit on a little bit about what you mean by that, and why traditionally we were taking out a lot of teeth to make room in the mouth, and now maybe that's not the wisest thing to do?
Sure. So I'm just going to give you kind of a very simplistic, view of all of that.
Idea about it.
But the tongue is key. It's actually attached way down deep in our sternum. Most people don't understand that. The tether is actually attached to our hyoid bone, which is underneath our chin. So the strength of that muscle has a lot to do with the posture that we have and how we open our airways. So the tongue is the king of the castle, is what I like to say, and it's really the elevation in the infant feeding side that's really important to go up and cup around that nipple. The nipple is truly just supposed to be the conduit of milk, not the damage taker, the lipstick shape that or the cracked and bleeding nipple. So all those are symptoms that the tongue's not oscillating right. It's not sucking right. The posterior portion of the tongue, which is the back portion, is not lifting. If we can't create a vacuum, you know what? These babies are really smart, okay? I need milk to survive. What do I have to do to get milk to survive? That's pretty much what I think babies are thinking about when they talk to each other. How do you get milk? This is how I get milk. And they compensate, right? We can compensate our whole entire lives, and people don't even know it. But it's really the compensation is the main thing I'm looking for at Health Latch. What is the compensation? Not what is the tongue tie. What is the compensation, and why is that happening? But in essence, if we decide, okay, if the tongue is just going to sit in the cave down the bottom and the floor of the mouth, we start to swallow with our external facial muscles. Now, everybody thinks that bone is the hardest thing in the body. It's actually our muscles adapt our bone just like clay, so it's really the tongue pushing out and the muscles from the outside pushing in that keep our teeth in balance. The teeth will actually move one way or another. They're like ships in the water. So if we're swallowing from the outside in, you basically will take the upper jaw in a very short period of time and start to mold that clay into what we call a high palate. And like I said, unfortunately, some of the babies I see, because they're so tongue-tied in utero, they come out with a high palate. Well, the suckling stimulus is way up in the palate in the back, and the nipple is supposed to kind of tickle that to get the suck and swallow to get started. But, you know, big picture, if we get that upper jaw that pivots, the lower mandible or the lower jaw usually follows suit. And I always say the lid and the jar don't fit together now. You know, the upper lid and the lower jar don't fit. And the perimeter of where the teeth can fit in take a hit. They just can't fit in anymore. So when you actually see someone smile and they have absolutely severe crowding and they have canines blocked out, it's not that they haven't seen the orthodontist. It's actually just that they've had an imbalance in their muscles that have caused that to happen.
Right.
So if you can imagine, the top of the mouth is the floor of the nose. And so when the top of the mouth pivots up, the nasal septum deviates. And a lot of those kids become open mouth breathers. And this is usually my conversation with the families, where the light bulbs start to turn on for the older kids that were maybe missed along the way. So when we change that pathway of breathing through our mouths versus breathing through our nose, that's not how nature intended it. If we were to hit our milestones, it would be lip seal, swallow across the palate, and breathe through our nose. Those three simple things. If you end up that way, you end up with a more healthy child, more robust, less allergies. But the big one that takes it to the next level of problems and health problems is when the tonsils enlarge from all the debris and the dust coming through the mouth instead of being purified through the nose, the tonsils enlarge. And I know that's a very simplistic way, but once the tonsils enlarge, you're now getting a closed airway. And the airway being closed is what's driving your future problems.
Right.
Okay, so those are kind of a simplistic version, and many times I saw when the permanent teeth started coming in, which is right around age 6 on the lower anterior, sometimes a little earlier for girls, we'd have 2 teeth come into a space where there was 4 baby teeth, and they would sometimes take up the entire space of the 4. Well, that imbalance is starting that process of extractions or the need to do something. And we're just coming
for the teeth.
Yeah.
So what we would do is taking out those teeth to make more room, but that sort of backfires after a while, right?
It does. And the neatest thing is, just in Seattle on Monday, Mayo Munchie came to Seattle, of which I don't get paid for to say the name, but they were here from Australia, a family that has this device that kids chew on. And truly just by chewing and pushing the muscles out and retraining the muscles, it's fixing cross bites. And the cross bites is where the upper and lower jaw don't fit together, and fixing other problems in terms of how we swallow. So if we have dysfunction, we can function our whole lives, but eventually it trickles down.
Yeah.
In the adult population, again, simplistic, is they're dealing with a lot of sleep apnea. And we're finding that younger and younger and younger. Yeah. And that's just where air is just not passing properly through the body or forcefully being passed through the body.
And there was a study recently published about the connection between sleep apnea in kids and ADHD and behaviorism. And I think it's great that this is finally coming to the forefront, because these poor kids are, nobody's looking at the cause for their issues. They're just treating them. And now if people are starting to have evidence that this could be related, and then we can get some interventions that can help these kids. Because the earlier this is found, the easier it is to deal with before things are developed, right?
And taking it back to babies, where my love is and your love is, I truly believe that whoever you believe made us, wanted the breast to be the first functional appliance of the airway.
I like that.
The architect of the airway. So I think by having that breast in there that's so malleable that can be sucked on, it then pushes on the maxilla. And if that tongue is oscillating correctly, to put it in perspective, your orthodontic brackets that move teeth through bone over time have about 50 grams of force. If you put more than 50 grams of force on a tooth, you can actually cause damage to the tooth. So that's why orthodontics takes some while to move the teeth to the right places. The tongue has about 400 grams of force.
Wow.
And you can see as it's applied to that bone, it applies everywhere if it's going to the right place. It's doming out the cathedral. So the bigger the dome on the top, the bigger the breath you can take. I can even see this eventually getting to athletics, right? I help coach a basketball team, and a lot of my players, the parents will come to me and they'll say, hey, can you help so-and-so shoot better or play better? And I actually have very interesting talks. Well, he can't run up and down the court 2 or 3 times because of the way he's postured and the way he breathes. I don't know if I can make him a better shooter, but I can get him a better airway. So I connect the dots. So, and it's so much easier to fix the problem from the beginning versus coming in afterwards.
Yeah.
So that's where I'm passionate about.
Yeah. I just want to take, because time is flying. This conversation has been wonderful and time is flying, but I want to look back at the questions on Facebook.
Sure.
And make sure that we're not missing anybody's questions. So give me 1 second while I open this up, and I have to make sure that we're not, sorry about that. Okay. We've got lots of people watching. It's great. Sometimes hard to find the questions.
No worries.
Not letting me going back. Let's see. So just for anybody who's here, if we don't get to your comments or questions, we will. Okay, so Marina says, fabulously informative presentation. This is a great question. How do you know how to choose a person for evaluation? So that's a great question, Amanda.
How do you think that's questioned, Lisa? How do you choose someone for evaluation of tongue?
Yeah, so I think that, in my opinion, you have to get recommendations from other families, whether that be, or if you don't know any other families, possibly, pages like my own, maybe even contacting someone else that's not near you. Like I'm sure Dr. Thomas, you have a network that you recommend around the country. Yeah. But pages like my own, I have a network. We have a network. You mentioned IATP. There's also ICAP. There's American Laser Study Club. There's a lot of organizations right now that allow providers to network. So if somebody called me today and said, I need to find somebody in California, I could find them someone. So that would be, to me, the best bet. But I would almost always say start with the IBCLC. Yep. And if you can't start with an IBCLC, or if you do start with an IBCLC and they don't answer your questions, they still may not have had the training in tongue tie. Yeah. So if you're not getting your answers, move on. And not to disparage any IBCLCs, because I was there. That was me before I learned about this. Yeah. So if I missed tongue ties, and like you say, you felt bad about the extractions, I feel bad about the tongue ties I missed early in my career. Because the same way you didn't learn this in dental school, I didn't learn this in nursing school, midwifery school, even when I was training to be an IBCLC. Yeah, yeah. So we have to go beyond. And what made me go beyond was that small, there was a growing number of babies that I did all my tricks and it didn't work. So something else was going on.
Yeah, and those are the fun ones.
Yeah, so I would say that groups like this, definitely reach out. There's always, don't ever give up looking for help. If you can't find someone, there's somebody who can help you find somebody who can help you find somebody.
Yeah, I was on a Facebook Live, I want to say like 6 months ago, and it was a lactation consultant who had quite a few followers. And I learned, I actually said, hey, if you need someone and you're somewhere in the country, email me at hello@healthlatch.com. And maybe I can do that again, because, for me, I've done everything. So I feel like I have some validity to say this. I used to use scissors, okay? I used a scalpel. I eventually used a diode laser, which eventually went to a CO2 laser for me, and that's where I'm at right now. To me, that was just like a progression of care and wanting to be better and better and better at the procedure and have better results. So when I came on the scene, kind of a tool as a tool was the scenario. And I still think there's people out there that are better than me with scissors and do good frenectomies, okay? But I think that when you start to surround yourself, if someone's looking for someone, you surround yourself with really good tools and you surround yourself with really good people. Like for me, that's an IBCLC in the office. I think parents, if that's questions coming from a parent, you can probably ask those different layers of questions and you can kind of figure out like, how much is this person putting into this procedure? Is it just, oh yeah, I do one, every 3 months. So you could maybe ask a number of how many they've done. Maybe they close down the office and they just do babies on one day, which is something I speak to the dentists about all the time. This shouldn't be, we just do one in between 2 cleanings. And I'm not trying to push my own philosophy on it. It's just things that I, with painful, experience has kind of steered me towards in terms of really taking good care of the family. So I would say as a parent, just really doing your research and asking those questions, and again, asking around to other parents of their experience, because I think moms and dads, but moms are very savvy and they know what kind of experience it was. So I think when they write online, I think they know, I truly think they know what they felt in that experience or the anxiety that maybe wasn't met. So yeah. And, I've toyed around with, using Health Latch as a preferred provider list, right? Because I do know the people that are really seeking out the, because you see each other and you know how it is. We all see each other at the meetings, right? We all could probably just take a charter plane and get to the same meeting, right? So we know who's functioning at a high level. And if you can imagine, those people know the people in their area that are functioning at a high level. So I think some of the way I want to go with Health Latch is to make that true preferred provider list, and have seminars like this. So we're working on it, but there's just two of us.
I know, right? So another thing is that, I have a course called Parents Guide to TOTS.
Oh, that's great.
The term TOTS, tethered oral tissues, in case anyone listening doesn't know what that means. So that's lip tie, tongue tie, buccal ties, any oral restrictions. So inside my course, there's actually a handout, what to ask the provider. So I've compiled a list of what to ask the provider before you let them touch your baby. It's a good list of questions to, like you were just saying, to say, how much do they do? Who do they work with? Do they understand the network? Are they going to, tell you what to do afterwards? Is there going to be support? Things like that. So if you want, I can actually post the link to that actual thing. I'll post that for the woman who asked the question.
Oh, that's great. That's a great resource. And just to kind of speak to that, we all got to remember where we were when we had our first baby, like on day 3, right? When we were told something was a little bit off on our baby, we were tired, exhausted, and honestly, we didn't even know the question to ask, right? Even if someone asked us, do you have any questions about this procedure or what we're doing? I mean, I remember not even knowing the question to ask. So I think that's a great resource, Lisa. I think that's a great thing you're doing.
Yeah. So there's another question from Jessica. How common is reattachment after laser revision? If it is found out that reattachment has occurred, say around the 3 or 4 month mark, would another revision be recommended?
Yeah, it's all case by case, obviously. And at the 3 month mark, you would be, looking at where your symptoms are, If that baby had tongue tie release and that baby started to grow and pain went down and milk continued and you're still breastfeeding at 3 to 4 months, and that is somewhat a sign of either mom supply is just continued forever and baby's not having to do anything, and that's an assessment you'd have to make, or the fact that the tongue is working just fine functionally, even after that release, that maybe doesn't look cosmetically perfect.
Right.
With the laser, I feel like I'm doing a frenectomy, which means that we are taking out of me a little bit of the collagen underneath the tissue. That's the beauty of how I made that evolution in my career to the tool I use now, which is a CO2 laser. Less bleeding, cauterization of nerve and artery, so baby's comfortable for about 4 hours afterwards. But it was really the fact that I like the ectomy part of it, which means that I am actually physically obliterating, which isn't more invasive. I actually wear surgical loops. I feather that tie away until I get to the exact point. One of the conclusions, because of all the misnomers on tongue tie out there, I show them a before and after picture of exactly what I did. And then lastly, I look them in the eye and I confidently say, now I want you to know that I took down, no matter how much your baby was crying for those 30 to 60 seconds, I went all the way to the base of the tongue and I took out the posterior tongue tie. That's probably the main thing that I'm having to retreat from other areas that babies come to me for the first time, is that the anterior portion of the tongue tie was taken care of, but not the posterior portion. So going back to answer the question, I would say it's an assessment. It's an assessment again at the 3-month mark, but typically I don't retreat if functionality is going very, very well. You stay out of the way at that point.
And isn't it but if there's a frenum there, again, it's not necessarily reattached, right? I mean, there is some regrowth back.
Yeah.
So it's a functional, it's not so much what it looks like, but it's what it does, right?
Yeah. You know, speaking to how Dr. Gahary talks about the mast and the sail, right? The anterior portion is the sail, right? If we take out the sail and we take out the posterior mast with the laser, right? We obliterate it or vaporize it. And I hate using that word with parents, vaporize. I feel like it's Star Wars, but the laser cuts at the depth of a skin of a tomato if you're using it right. So we take out that posterior portion. So I feel confident that I did the ectomy every single time. Right. So and then I follow that up in my post-op talk, because the post-op is very important for the exercises. I feel like my exercises are there to make sure it heals as appropriately as possible. You're not trying to prevent reattachment. You're trying to get it to heal as best as possible with the laser. Okay, so what I was trying to do in that progression of tools was eliminate the error. And there's a lot of error in these procedures because you're then handing this baby off to parents to do exercises. So I felt by climbing the chain in terms of the tool, I was eliminating the possibility. And so I have very, very few reattachments. It's a rare breed. And then again, I'm reassessing for functionality if that does come back to me.
Yeah. So what I would say, just as a simple answer to that, is I always like to have parents make a list of what are the reasons that we're having the procedure. For the procedure. I'll actually write that in my note and send, that's part of the report they get. What are the reasons? And then afterwards, did those things improve? And then to look for those things if they come back or not. That's more important, the assessment. So for the I believe it was Jessica that asked the question. I would say look for the reasons that the procedure was done and see if they're healed or if they're returned. So that would be. And then my first go-to, if there's any return of symptoms, is we do an assessment to see if mom and dad are doing the exercises right. And then after that, it's always body work first, because it may not be reattached. It may just be that the baby is just so tense here, or has a little torticollis where it's hard for them to open up well. So I always go to body work, after that.
One of the main, it's kind of interesting, one of the main things that I usually get a call for is that baby won't take the bottle after the procedure, and prefers the breast more than the bottle at that point. which it's a hard one to deal with, right? Because we have realistic problems where mom wants to break and she wants to go out with the girls, or, she, and there's ways around that. Yeah.
We'll go back to work. We have a lot
go
of
back to
moms
work.
go back to work really early.
That's right. That's right. I totally understand that, and it's kind of this juxtaposition, because this is what we wanted, right? And now we're struggling with the bottle, and it's an interesting thing. Never thought I would deal with that, right? Because we're having so many people come to Health Latch because all they want to do is exclusively breastfeed, right? And but yeah, no, it's been a lot of great stories. Lastly, one of the things I'm really passionate about, if I could just take a second, is sharing those stories, whether it be through Instagram, because if I was to tell you the transformation that happens, right? Because really mom and dad are trying to get from point A to point B, and you're just the conduit that helps them get there. But the trap of that story is very important in growing what I would say is the movement for breastfeeding, let alone it be tongue-tied to breastfeeding. So I encourage practitioners, it's not so much about growing themselves or their brand, it's just that you ask parents to share the story back with pediatrician, or share the story at a dinner table. We've kind of lost the art in our culture of sharing stories, and those are success stories. So I encourage, if you go to the Health Latch, just healthlatch.com page, you'll see a section where we just highlight stories, which is where mom and baby came in and what they were thinking about. Because to me, what happens there is people find pages like mine and they read the story and they say, hey, that's my kid. That's my problem. That's my aerosphagia, or my reflux, or my gas. So you're just basically helping people find the care they need just by telling a simple story. So.
Yeah. Thank you. So we're actually over time. This was a
great
conversation. No, don't apologize. It was wonderful. And I know that a lot of people will learn from the topics that we discussed. But before we go, just tell us a little bit. So you mentioned your Facebook, you have an Instagram. It's all called Health Latch.
Yeah, I mean, the main thing
places as Health Latch, they'll find you.
Yeah, the main thing I would say, there's 3 phases of Health Latch, and we're just completing the first phase. There's 2. I have really big aspirations for where I want it to go and how many people I want it to help. I would say if people just go to health.latch, which is our Instagram page, that's probably the best way to follow me. I don't post super often. I like that kind of slow post as they come out naturally. I don't do any marketing. I like natural, how things grow naturally. But I think that's where most of it's going to come through, different things that I'm trying, and some of them are going to fail and some of them are going to succeed, and we'll learn along the way. But I'm very passionate about supporting IBCLCs and kind of lifting them up and kind of taking the background behind them.
Wow, that's great. So so just, if anybody wants to look under the Facebook Live here today, there'll be links to, I do have the tongue tie course. I also have my book. My book is called It Shouldn't Hurt to Nurse Your Baby, which I believe everybody needs to get that message across. It's a little controversial because some people believe that it should hurt in the beginning or whatever. It shouldn't hurt to nurse your baby, ever. If it hurts, reach out for help.
Yeah.
And I would love for you to come to my Instagram for anybody who's watching and listening, because I'm growing that brand. That's finally happening for me. I've been on Facebook for a while, but Instagram is fun and exciting, and there's lots of moms. And I do feel like young families are learning a lot from Instagram too. So there too. And I am also available for virtual consults. So there'll be a link under this live too, in case anybody doesn't have somebody in their area, or if you just want some, guidance from me. It's not the same as an in-person consult, but my information is there, and it's basically a teaching opportunity and a learning opportunity for parents who need help, further help than we can do on a Facebook page.
And when do you sleep? That's a lot.
Do I sleep? No, I sleep. I like to sleep. Just drink a lot of coffee all day long.
Well, it was a pleasure, Lisa. Thank you so much.
It's so great, Dr. Thomas. Thank you so much for being with us today, and enjoy the rest of your day.
Okay. All right. Have a good one.
All right. Take care.
Bye.